Today we have gathered here to have a discussion on two topics. One of them is hypertension. It's a common topic, a little boring topic because you've been doing it every day. I'll try to make it a little more interesting, a little more catchy, a little few take-home messages. And let's look at the history and how the blood pressure was measured in the initial years. The first to measure the blood pressure was Stephen Hales in the year 1733, and he measured the height of a column of blood after cannulating the carotid artery in a horse with a brass pipe. Once he connected to the brass pipe, he used a glass tube. A 12 centimeter glass tube was used at the top to see the height of the column, and the tube and the brass pipe were connected with the trachea of a goose to know what is the height of the column of the blood pressure to which it would rise. This was 1733. And about 100 years later, the mercury manometer was discovered, and again that was used to connect to the artery to measure the blood pressure. Both procedures were invasive and was quite painful probably. In the year 1890, an Italian physician, Rivarossi, invented the sphygmomanometer. Sphygmo meaning pulse, manometer meaning pressure meter. This consists of a mercury column, what we have the modern mercury manometer, a rubber sleeve which is filled with air and a squeeze bag to inflate the rubber sleeve. And that's how the blood pressure apparatus was invented in 1890. Let's look at briefly the history of hypertension. This is how the hypertension. Can we have the lights down? I think the slides will not be visible. The lights are focusing on the screens. Okay. Yeah, I think that's better. Can you all see the slide? Right, thanks. Now, if you look at the initial years, it was in the year 1963 in US, the Veterans Affairs Hospital, they did a study on 184 men who had hypertension, and the blood pressure target was the diastolic blood pressure. In those years, the blood pressure was basically diastolic hypertension. The systolic hypertension was not a concept at all. In the initial years, that was in the initial years when 1960s, early 1960s and 70s, it was basically the diastolic hypertension which was taken as a cutoff point, and a blood pressure of more than 100 to 115 diastolic pressure. That group of people were treated, and they found that when they treated the blood pressure, diastolic blood pressure, there was a significant decrease in the incidence of stroke and myocardial infarction. Subsequent almost 60 to almost 80s, systolic blood pressure was not a recommendation. Do you have another pointer? Systolic blood pressure was not a recommendation at all. Systolic blood pressure was not a recommendation at all initial years for the control of blood pressure. It was not a target, it was not a goal. It was basically the diastolic blood pressure. However, as some of the studies started coming in, the HDFP trial, the Australian trial, the MRC trial, all these trials put in a concept and said, probably the diastolic goal for initiating therapy should have been a diastolic blood pressure of 105. The JNC1 and the JNC2 said in 1977 and 80 that the diastolic blood pressure initiating the treatment was diastolic blood pressure of 105, very high to what we are doing today. Subsequently, in the 1985, the systolic hypertension was recognized as one of the targets of treatment, and the JNC3 in 1984 said, if you start treating, the threshold for starting a hypertension treatment would be a systolic blood pressure of 160. This is as late as 1980s, we started this concept of treating the systolic blood pressure. There was no recommendation till then about systolic blood pressure. Later on, gradually, the blood pressure target started coming down, and the target was 140 systolic blood pressure in JNC5 1993. And the diastolic blood pressure target was decreased from 105 to 95 to 90 in JNC5. So the targets of blood pressure of 140 by 90 was reached in the year 1993 in the JNC5 recommendations. And gradually, over a lot of studies have been coming. All the alphabets what you have here, the SHEP trial, the STOP trial, CIST European trial, the HOT, ALHAT, HIVET, ACCORD, SPRINT, HOPE 3, all this in the timeline of 1995 to 2016, we have a lot of trials which have given us enough evidence from randomized controlled trials that what should be the targets, when should you initiate the treatment of hypertension, what should be the target of blood pressure. Today, medical science has made such tremendous advances that there is no healthy human left. Every one of us, when we are born itself, have the genomes imprinted, and the genomes will tell us that we do carry disease. You may be thinking you are healthy, but when you do your routine blood tests, when you do your liver function tests, your vitamin D levels, vitamin B12 levels, or probably you look at your rheumatic profile and the connective tissue disease profile, you'll find something abnormal. Or probably if everything is normal, if you look at your genome, probably you're carrying the gene which is responsible for a premature coronary artery disease or a gene for hypertension. So medical science is picking up disease at a very, very early stage, and hypertension is one such place where the genetic therapy is also coming in for the management of hypertension. Let's look at the burden of hypertension in the society. It's the most common, readily identifiable and reversible risk factor for cardiovascular disease, myocardial infarction, stroke, heart failure, and kidney disease. Hypertension currently causes 2/3 of all strokes and half of all cases of ischemic heart disease. So the maximum contribution for hypertension is for stroke rather than for the ischemic heart disease. Half of this occurs in patients who are hypertensive, and the other halves in pre-hypertension are patients who have high normal blood pressure. Most of the individuals, half of them have a high normal blood pressure, they do not have a hypertension. The asymptomatic nature of this condition delays the diagnosis, and hence the name, the silent killer for this entity. So the goal of therapy is to avoid a target organ damage. And when we treat hypertension, over the years, we reduce the coronary events by 20 to 30%, we reduce the incidence of stroke by about 30 to 40%, reduce the incidence of congestive heart failure by 50% in the long run. So the effect on the ischemic heart disease is much less than the effect on the stroke, and the effect of reducing congestive heart failure is much more powerful for treating hypertension. These are the benefits of treating hypertension, and this is how you reduce the target organ damage. And how do you assess in a patient who has hypertension, which is a silent disease, how do you assess a target organ damage? And we assess the target organ damage by looking at the pulse pressure, especially if the pulse pressure is more than 60 millimeters of mercury in the elderly. You already have a stiffening arterial vessel. The arterial vessel wall is stiffening, and he is already having a target organ damage. The vessel wall is a target organ. If you have an ECG evidence of left ventricular hypertrophy, an echo evidence of left ventricular hypertrophy, a carotid intima media thickness of more than 0.9 centimeter, a carotid plaque telling us the initial stages of atherosclerosis has already begun, the ankle brachial index of less than 0.9, a chronic kidney disease, or a microalbuminuria. For a silent disease, one has to make endeavors to pick up silent target organ damage. And these are the various entities which you can pick up silently. Without you, the patient would not have any complaints. And that's how you pick up a silent asymptomatic target organ damage. And if one of the patients who has a high normal blood pressure, whom you think is a high normal blood or pre-hypertension, who has evidence of a target organ damage, that individual should be targeted very aggressively, and the hypertension should be treated. We'll talk about it in the subsequent slides. But then, blood pressure measurement is a clinical procedure of greatest importance. But then when you look at it, when I look at the nurses, when I look at the junior doctors who do the measurement, it is performed in the sloppiest manner. This was said by Kaplan Mayer in 1998. So what is important is how we measure the blood pressure. In the earlier days, when the recommendations were coming from the various societies, the American Heart Association, the American College of Cardiology, the European Society of Cardiology, the Japanese Society, the Canadian Society, every organization has given up the guidelines and methods of measuring blood pressure. But today, if you compare the office blood pressure versus the out-of-office blood pressure, one thing stands out: the out-of-office blood pressure is much more important than the office blood pressure. So the office blood pressure is considered the gold standard of measuring. The patient comes to the clinic, you measure the blood pressure and you say, he has a hypertension, he has no hypertension, he is a normotensive individual. But that is not important. That doesn't end the story. The story, the final say is in measuring the home blood pressure. The final say is measuring the 24-hour ambulatory blood pressure to know what affects the long-term outcomes of treating hypertension or the hypertension as a disease entity. Of course, in the core lab, in the investigative lab, one does measure the central aortic pressure, which is not recommended to measure in the routine clinical practice. And of course, in the intensive care, you do the invasive arterial monitoring to taper the drugs or titrate the dosage of the drugs what we give in our intensive care. So today here we are going to discuss about a few of the controversies and what is the consensus we have achieved. By going over these controversies, this is what we are going to discuss today. One is we are going to talk about the goal blood pressure. We are going to define a goal and say on what basis we have defined a blood pressure of 140/90. The slogan, lower is better, is always there. Lower is better has been proved for hypertension as well as for lipid levels. But lower is better, how far it is true, let us find out today. The guidelines, like Dr. Raghuraman has said, have been confusing a lot. Each society gives a new guideline every other year, and the guidelines have been confusing. Should you treat grade 1 hypertension? Is one question which I would like to ask. Should you treat high normal blood pressure? Is the second question, which is very, very important. Because if you see the first slide, half of the individuals who have a stroke or who have a myocardial infarction or an ischemic event are in the high normal range. So should you treat this group of patients? What is the evidence today we have? Lower is better, but watch for the J-curve effect. This is a school of thought that there is a J-curve phenomenon with hypertension management, and probably if you lower the diastolic pressure too low, lower the systolic pressure too low, you're going to have an increased incidence of coronary as well as stroke events. So let's look at that evidence too. And most important, today we have various methods of measuring the blood pressure. The mercury manometer is being phased out. The WHO has said no more manufacturing of the mercury manometers. We're still using it in our hospitals, but probably gradually over the years we'll be phasing out, like Modi has phased out the 500 and 1,000 rupee notes. The digital apparatuses are coming in today and probably are going to stay here for a long time. The digital apparatus is what you see at the machines outside and the pharmaceutical shops. The oscillometric method, this is the most important, most accurate technical method of measuring the blood pressure. This is what you see in your ambulatory blood pressure monitors. And the ambulatory blood pressure monitors use the technique of oscillometric method, wherein there is a small piezoelectric chip which measures the oscillations of the artery there and measures the technique. And this technique is much superior over the digital technique, and this is much superior over the mercury manometer. Mercury manometer and the digital manometers have to be calibrated at regular intervals to tell them that they have been doing an accurate job, which we don't do. Probably I have an apparatus in my clinic which has not been calibrated for the last 5 years. They all have to be calibrated. This oscillometric technique doesn't need a calibration because it comes with an internal calibration and it does its own measurement, and this is the most accurate technique. Of course, we'll talk about a few slides about role of ambulatory blood pressure monitoring. I did give a talk on the same podium here in this Karimnagar town about the ambulatory blood pressure monitoring. We will look at the recent trials and the practical implications, the SPRINT and HOPE-3 trial, certain special instances of hypertension, diabetes and chronic kidney disease, a word of information about chronopharmacology and about renal artery stenting and renal denervation. I have said in my initial slide, lower is better. The lower the diastolic blood pressure, the lower the systolic blood pressure, the better is the prognosis. The lesser the incidence of stroke, the lesser the incidence of myocardial ischemic events, and the lesser the incidence of congestive heart failure. Now this slope is quite steep if you look at it. If you look at it, as the blood pressure goes from 120 to 180, the curve is very steep, and as the age advances, the curve is higher and higher. The slope of the curve is quite higher and higher. The ischemic heart disease rates by the systolic blood pressure, diastolic blood pressure, and the age keep rising. The higher the blood pressure, both systolic and diastolic, the higher the age, the higher the event rate. These were the few trials, landmark trials. The SHEP trial, which has clearly shown if you treat a blood pressure, if you treat a blood pressure, systolic blood pressure which is very high, with an antihypertensive drug using chlorthalidone and other drugs if needed, you have a significant 36% reduction in mortality as early as 72 months. And if you look at the CIST Europe trial, again another important trial where they have used nitrandipine with enalapril with hydrochlorothiazide, both the incidence of fatal and non-fatal strokes and non-fatal myocardial infarction, there is a 42% reduction in stroke, 30% reduction in coronary events. A significant reduction. In the elderly hypertensives, hypertension management in the elderly hypertensives, when you treat hypertension with the antihypertensive drugs with placebo, 21% reduction in mortality with the active treatment is noted with this trial. So these trials have very clearly shown that achieving systolic blood pressure of less than 160 is of benefit. Very clearly they have shown from the 60s to the early 90s, goal of blood pressure less than 160 was benefit. Initial years, the goal of blood pressure was 160. Achieving a systolic blood pressure of less than 150 is also of benefit. This has again been proven by trials. Achieving a systolic blood pressure of less than 140 also appears to be justified, though evidence is not as rigorous as for the higher thresholds of 150 and 160. 140 is the cutoff line which most of the guidelines recommend. Achieving systolic blood pressure of less than 130 doesn't provide better outcomes, but appears safe. A new trial has come, the SPRINT trial, which has very clearly shown that this level of blood pressure is safe. Achieving a systolic blood pressure of less than 140 is clearly beneficial for reducing the incidence of stroke, not for coronary events. So these are the various targets which we have tried to achieve over the timeline of 1960s to the 2016. And what is important is there is a lot of consensus opinion and some discrepancies between the guidelines. If you look at measuring the blood pressure, multiple office blood pressure measurements are the gold standard for diagnosis, not just one reading. 3 readings, 4 readings, 5 readings, multiple readings have to be taken before you label anyone as hypertension. Stage 1 or stage 2 or whatever you want to label. However, there is a small discrepancy. NICE from United Kingdom states that ambulatory blood pressure is the gold standard for diagnosis before initiating therapy. So they will not dispense the drug in United Kingdom if you have not done a 24-hour blood pressure monitoring and then proven that this patient is having hypertension, not just on a clinic recording or an office recording. So that is the discrepancy what they have seen, and probably in the right way, the daytime average of more than 135/85 is defined as hypertension for the NICE recommendations. If you look at the target office blood pressure, almost all for the general population blood pressure of less than 140/90, but there is a different target for the elderly. The JNC8 said the target for the elderly is 150. In some 80 plus individuals who are frail, even 160 is acceptable. So the targets for the general population is 140/90, but for the elderly there is a small change. If you look at the recommendations of health behavior, lifestyle modification, A few of the societies have said we would like to try lifestyle modification for at least 3 to 6 months before initiating therapy. Whereas some of the societies have very clearly said that they would like to start the pharmacological drugs along with the lifestyle modification. So if you look at stage 1 hypertension, which is with a low risk, almost all the societies, American Society, the European Society, as well as the NICE, all of them said health behavior modifications and monitoring before initiating pharmacological treatment. Almost all the societies have said lifestyle modification. And if you look at the stage 1 high risk individuals, almost all the societies have uniformly agreed that lifestyle modification and pharmacological treatment has to start simultaneously. If you look at the stage 2 low risk individuals, the European Society of Cardiology says lifestyle modifications before initiating pharmacological treatment. No other society says lifestyle modification separately before initiating the pharmacological treatment. But there are some discrepancies in the guidelines which is adding to the confusion. And of course, the general guidelines we all are familiar, a goal of less than 140 by 90. For an age group of more than 60 years, the goal is 150 by 90. More than 80 years, less than 150 by 90. If the patient is more than 80 years and is frail and fragile, probably a higher blood pressure of 160 also should be acceptable. For the diabetic patients and for the chronic kidney disease patients, a goal of 130 by 80 is what is recommended. These are the various guidelines and these are the various societies which have come here, which have very clearly shown that, but more or less there is a strong consensus is what they have to do. The Canadian Society also has given a guideline and said a target blood pressure of less than 140 by 90 for all the patients, a lifestyle modification with the drugs of various classes, diuretics, ACE inhibitors, ARB, calcium channel blockers. Beta blockers, they have said, should not be given in patients who are less than 60 years. This is the Canadian Association recommendation, not very strong. But what is new in this Canadian recommendation 2015 is clinic blood pressure should be using oscillometric monitors. This is the standard way to go. The diagnosis of hypertension should be based on out-of-office measurements, not a just clinic measurement, but out-of-office blood pressure BP measurement is what should be the gold standard. This is the new recommendations. And the management of hypertension is all about global risk management and vascular protection, including advice and treatment of smoking cessation. So there's a grouping of risk factors in patients who have hypertension. They have diabetes, they have dyslipidemia, they have hyperuricemia. So all this, a global risk assessment has to be done, not just treating the numbers of hypertension. So when do we initiate antihypertensive treatment? When you have a grade 2 and grade 3 hypertension. When the blood pressure is more than 160, more than 180, there's a definite evidence from the various trials that hypertension should be treated. Grade 1 hypertension, again there's a definite evidence that it should be treated. Grade 1 hypertension in the elderly, definite evidence it should be treated. Anybody who's having a blood pressure of more than 160 is having a higher incidence of stroke. The blood pressure goal in a patient for whom you have to reduce the incidence of stroke is less than 120 by 80. High normal blood pressure, there is no evidence today. There is no evidence from the trials today that this group of patients should be treated. And some recent trials have come in. One of them is the SPRINT trial, wherein a randomized trial of intense versus standard blood pressure control. And this trial was done in about 9,361 patients, with patients who have a systolic blood pressure of 130 to 180, who are at an increased risk of cardiovascular events, who have a metabolic syndrome, who have microalbuminuria, who have a hypertension, who have dyslipidemia, who have a mild renal disease. These are the patients who were taken for the trial there. And they have targeted the systolic blood pressure to less than 140 in the standard treatment group and less than 120 in the intense treatment group. There were no diabetics. Diabetics were excluded in this study. And the primary outcome was outcome of myocardial infarction, acute coronary syndrome, stroke, acute decompensated heart failure, or death from cardiovascular cause. And what they found over a duration of 3.5 years, when they followed up these patients, they found that there's a 25% relative risk reduction in the primary outcome of acute ischemic event, both cardiac and stroke. 25% risk reduction, and a 27% lower relative risk of death from any cause. All-cause mortality was 27% less in the SPRINT trial. So this was a population who is at intermediate risk, who have a blood pressure of 130 to 180, non-diabetics, when they treated the blood pressure to a goal of 120/80, there was a significant reduction in cardiovascular events as well as mortality. So the sprint trial concluded that among adults with hypertension but without diabetes, lowering systolic blood pressure to less than 180 as compared with the standard goal of 140 resulted in significantly lower rates of fatal and non-fatal cardiovascular events. This trial has challenged the guidelines which have come with a target of 140/80 blood pressure. The sprint implications in our practice: at each visit, the patient should be, the technique of recording blood pressure in the sprint trial was something different. The patient was taken to the room, left alone there with the blood pressure machine, which is an automatic machine, and it takes 3 readings in a span of 5 minutes, and the average of the 3 readings was taken to measure the blood pressure. BP was recorded by commercially available automated unit that recorded 3 readings separated by several minutes with no clinician in the room. There is no disturbance. That office effect, the white coat effect is not seen there. Decisions were made on the average of the 3 readings. So the average of the 3 readings was taken, and this method of blood pressure measurement yields substantially lower readings than a single rushed measurement typical in many practices. So when the patient rushes into a clinic, you measure the blood pressure, it's usually higher by 5 to 10 millimeters of mercury. So this technique of recording blood pressure is what is important, and if sprint is applied without attention to proper blood pressure measurement, substantial overtreatment would have been done with a higher rate of adverse events that would have occurred. So this goal of 120/80 is important, but this was with a different technique, method of measurement, this blood pressure. A court study which has come in the New England Journal of Medicine in 2010, when they compared effects of intensive blood pressure control in type 2 diabetes, the previous study was without non-diabetics, they found that there was no advantage between the intensive group and the standard group when they did an intensive blood pressure control with a target of less than 120/80. In the diabetics, this did not show any benefit. Why did these 2 studies differ? Probably ECHORT did enroll diabetics, this excluded diabetics. The sample size was very large, the sprint is much more powerful data there. This was a relatively younger age group of 60 years, mean age group, this was 68 years older. So they probably had a better protection in the sprint trial when compared to the ECHORT trial. And what do the Indian guidelines say? The optimal normal blood pressure of less than 140 in the young and middle-aged. For the young and middle-aged general population, 140/90. In diabetic patients, lowering to around 140 is recommended, 140/80. In patients who have survived a stroke, 130/85. In elderly patients with high normal blood pressure, 140 to 145/90 should be taken as the blood pressure target. So the Indian guidelines have very clearly said that probably 140/90 is the goal, and in the elderly you need to have a word of caution, a little higher blood pressure of up to 150/90. The European Society of Cardiology has given a similar guidelines, but a diastolic blood pressure of less than 90 is always recommended, especially except in patients with diabetes who have a value of less than 85, or probably a value of between 80 to 85 is recommended. This was another trial which came in recently in 2016. They said among patients with intermediate cardiovascular risk with normal or lower blood pressure, normal blood pressure or high normal blood pressure, when they were treated with antihypertensives, this is the class which is controversial, with a co-primary outcome of death, non-fatal MI, non-fatal stroke, resuscitated cardiac arrest, heart failure or revascularization. The study groups being 4 groups getting candistatin with hydrochlorothiazide, rosuvastatin, candistatin with hydrochlorothiazide versus placebo, placebo versus placebo. About 12,000 patients studied in the trial, and they found that treating hypertension, the intermediate risk group population with a high normal blood pressure, not a very high blood pressure, with a high normal blood pressure, there was no difference between placebo and the candistatin hydrochlorothiazide group. So treating high blood pressure and treating hypertension in the high normal range with intermediate risk factors, there was no significant differences in individual components of the outcomes, total mortality or new onset diabetes mellitus. However, in the higher range of blood pressure, when blood pressure was more than 143 or 144, there was a slight tendency for advantage of candistatin with hydrochlorothiazide as compared to placebo. So in the subgroup analysis, they found that if the blood pressure is on the high normal range, 140 plus, there was a significant benefit of lowering stroke, but not cardiovascular events. So HOPE 3 has again laid a special recommendation to the proper assessment of the blood pressure, and the comments of the authors, our findings contradict the concept of lower is better, because by lowering the blood pressure to less than 120, to 130 to 120, they have not found any major benefit of using antihypertensive drugs. However, there is in the HOPE 3, there was a lipid arm. This is the hypertensive arm. The lipid arm has clearly shown that there is an advantage of using rosuvastatin 10 milligrams. Whatever be the lipid level, whatever be the blood pressure level, it has definitely reduced the incidence of cardiovascular events and stroke. We have the role of ambulatory blood pressure monitoring, which is very, very well known. It is known to detect white coat hypertension, which is defined as high blood pressure in the clinic, normal blood pressure, out of office recording, and masked hypertension, which is exactly the opposite of white coat hypertension, wherein the clinic blood pressure is normal, but the home blood pressure is on the higher side. Masked hypertension, the nocturnal blood pressure, and certain dipping patterns, which we'll talk in the next slide. Nocturnal hypertension, postural hypertension, these are a few entities which can be picked up only by doing a 24-hour ambulatory blood pressure monitoring. So the goals again are different. The goals for an ambulatory blood pressure monitoring for the daytime is 140 by 90. For the night time, the blood pressure should be 120 by 75. And for a mean average blood pressure over 24 hours, it should be 130 by 80. So the goal again for a 24 ambulatory blood pressure monitoring is different from the goals which have been set for a clinic blood pressure recording. These are a few patterns of nocturnal blood pressure behavior which we should be aware of. One of them is a dipping pattern wherein the nocturnal fall in blood pressure of more than 10% of the daytime value is important, which is normal. All of us should experience this normal dipping pattern of drop in blood pressure by 10% in the night times. There are a few group of individuals who have a non-dipping pattern. There is an absence of a nocturnal fall in blood pressure by more than 10%. And this is the obstructive sleep apnea, chronic kidney disease, metabolic syndrome group of patients. This group of patients who are non-dippers have a higher incidence of cardiovascular events. Reverse dipping is one entity wherein there is an increase in blood pressure levels during sleep to levels higher than the daytime. The daytime blood pressure is 140 by 90, the nighttime blood pressure is 160, 170. Reverse dipping. This pattern of blood pressure is producing a maximum damage to the cardiovascular system, the vascular system, and there is a highest incidence of stroke in the group of patients who have a reverse dipping pattern. Extreme dipping is a fall in blood pressure by more than 30% in the nights. So they have a fall in blood pressure more than 30%. And these are the group of individuals who have nocturnal falls. When they go to the washroom, when they get up from the bed and go to the washroom, they have a fall and a syncope. Extreme dipping. And a morning surge in blood pressure, and that is where you have a higher incidence of myocardial infarction. These are the group of individuals which you cannot pick up if you have not done a 24-hour blood pressure monitoring. So today, most of the societies are recommending that you do a 24-hour blood pressure monitoring to identify at least once a year to pick up what are the dipping patterns, what is the behavior of the blood pressure with medications or without medications. And one important study which I have come across is the Dublin outcome study, which has very clearly shown that if you give a prognostic importance to the blood pressure, the clinic blood pressure has got least prognostic value. The next best prognostic value is for the daytime blood pressure, and the next best value is for the 24-hour blood pressure. But the highest predictor of cardiovascular events is the nocturnal blood pressure, the nighttime blood pressure. The nighttime blood pressure predicts cardiovascular events much more powerfully than the daytime blood pressure. And again, a very important thing, since the blood pressure at the night is the deciding factor, a concept has arisen, a chronopharmacology or chronotherapy, wherein the blood pressure tablet is given in the night. At least one antihypertensive given in the night reduces the cardiovascular events in this very important study by 67% reduction in cardiovascular events if one drug is given in the blood time. So if you have 2 or 3 antihypertensive drugs to be given, one drug should be given in the night time so that the nocturnal blood pressure is well controlled and you have a more smoother blood pressure control with a nocturnal dip in the pattern and you have lesser cardiovascular events. This is one study called the INVEST study, which has looked upon at the J-curve phenomenon of the blood pressure management, and it is very clearly shown if your blood pressure is in the range of 91 to 100, 100, 110, 100, more than 110, the incidence of stroke is high. The higher the diastolic blood pressure, the higher the incidence of stroke. But when you look at the lowest incidence of stroke is between 71 to 80. If the blood pressure, diastolic blood pressure falls below 70, 61 to 70, less than 60, the incidence of stroke is not rising, but the incidence of myocardial infarction is rising there. So the lower the diastolic pressure, the higher the incidence of myocardial infarction. This is the J-curve phenomenon which is described. Not all studies, not all authors have agreed on this concept, but definitely this is an entity which is there. And when you compare ACE inhibitors with ARBs, there is a significant advantage of ACE inhibitors over the AR2 blockers. The newer drugs, AR2 blockers, have flooded the market. It's a very important group of drugs which we use for treating hypertension. But when you see RAS inhibition as an entity, and you look at all-cause mortality, if you compare ACE inhibitors versus ARBs, the benefit for ACE inhibitors is significant, whereas for ARBs is almost neutral. Let's look at this particular slide, which is clearly shown that if you look at the effect of ACE inhibitors and ARBs on mortality in diabetic patients, the relative risk reduction with ACE inhibitors is 21%, whereas the relative risk reduction with AR2 blockers is just 1%. So significant advantage of ACE inhibitors over AR2 blockers. However, the tolerance being an issue with a cough and an angioedema issue, the advantage of ARBs is there. Otherwise, ACE inhibitors score far superior to AR2 blockers. This is one controversy which has been there for quite some time. Should you treat a patient with ARB first or an ACE inhibitor first? The choice by statistics says your first choice should be ACE inhibitors. If it is not being tolerated, then switch over to an AR2 blocker. And if you look at RAS blockade in diabetic kidney disease prevention, ACE inhibitors reduce microalbuminuria by 29%. They reduce microalbuminuria by 29%, whereas AR2 blockers reduce it by 10%. So the advantage, ACE inhibitors reduce microalbuminuria significantly. The better the microalbuminuria being reduced, the lesser the cardiovascular events. Now let's look at the mortality. ACE inhibitors reduce mortality by 16%, whereas AR2 blockers increase mortality by 12%. Very difficult data, contrary to the practice what we are having. So this again is one area where ACE inhibitors have been found to prevent new onset diabetic kidney disease and death in the normal people with diabetes mellitus. This is a very strong data to suggest that ACE inhibitors should be the first drugs of choice and not AR2 blockers. So ladies and gentlemen, the key clinical take-home messages: white coat hypertension and masked hypertension are real entities. One has to use a 24-hour blood pressure monitoring. Lifestyle modification has to be initiated along with medications. Look at various cardiovascular risk factors, not just a number of hypertension. Nocturnal dipping patterns are important. If you compare ACE versus ARB, ACE is better. Target goals have to be specified and written clearly. Every group of individual you need to specify and write on the paper your target blood pressure 140 by 90, your target blood pressure 160 by 90, your target blood pressure 130 by 80 for a diabetic patient. Diabetic patient with proteinuria, the goal is again different. And if you look at the Indian guidelines, again they say an average of 3 readings, at least sit for 5 minutes, blood pressure should be in sitting or supine position, the arm should be bared and supported at the level of the heart, and you should measure at the first visit the blood pressure in both the arms. And the Indian hypertension guidelines recommends all the 4 group of drugs, the ACE inhibitors, the calcium channel blockers, the beta blockers and the diuretic. Some societies have said beta blockers should not be used as a first line of antihypertensive. Polypills do definitely increase the adherence, the compliance of the patient is better. The combination therapy is gaining ground because drug compliance is better, especially if there are 2 or more drugs for antihypertensives. Indian guidelines have suggested a fixed dose formulations to be considered to improve the compliance of the patients, and definitely a fixed dose combination like a polypill might be a useful tool against cardiovascular disease. Beta blockers was a controversy with atenolol, but the newer group of beta blockers like the carvedilol, metoprolol and nebivolol are definitely here to stay. They are much better group of drug. The 3rd generation beta blockers are definitely a first line option for management of hypertension. In diabetics with kidney disease, the blood pressure goal is 130 by 80, and less than 130 by 80 for patients who have microalbuminuria, and in kidney transplant recipients is less than 130 by 80. For elderly people with chronic kidney disease, 140 by 90 is diastolic is recommended. This is the recommendations, but for all patients with diabetes, 130 by 80, especially if albuminuria is present, this should be the way it should be treated. That should be the goal for patients who have hypertension and diabetes mellitus. It's a major public health problem. The methodology to measure blood pressure should be given a due importance, and AB 24 hours blood pressure should be at least done once a year. Recent trials have put a little controversy. There might be a change in the targets. The targets may be moving. We are trying to aim at a lower blood pressure of 120 by 80 today with the SPRINT trial. Probably the next guideline it will be changing. The choice of drugs for controlling blood pressure should be individualized. You can use any drug from any of the 4 classes of drugs. Doesn't make a difference. Basically, the numbers have to come down. How you bring down the blood pressure is what is important. The drug, the choice of drug may not be so important as the number coming down. Till more data emerge, evening doses of antihypertensive drug is recommended if you have taken more than 2 antihypertensive drugs. And it is high time that in India we have our own cardiovascular outcome trials. Thank you for your patient hearing.